Kia ora and welcome to Menopause and Arthritis, the podcast where we break down the dual challenge of managing menopause and arthritis. Ko Joe Miller toko ingoa. Hi, I'm Joe Miller from Arthritis New Zealand, Matapona Pona Aotearoa, and I'm here to guide you through expert insights, real stories, and practical advice to help you manage your health with confidence. A little bit about me. I'm currently training to become a psychologist, and I provide mental health support as part of our Arthritis Assist services. With an interest in women's health and aging, and having gone through menopause myself, I'm passionate about increasing awareness and helping women manage this stage of life, especially with arthritis. Each episode will chat with subject matter experts, health professionals and advocates to uncover what's really going on with your joints, hormones and overall well-being. Whether you're navigating symptoms yourself or supporting a loved one, this is the place to get the knowledge and support you need. So let's get started, because understanding your body is the first step to feeling your best. You've kind of probably brought us now on more onto the hormone replacement therapy, and I guess then now's probably maybe a good time to talk about the pros and cons, and I guess how women can use it to help benefit that pain as well.
So fundamentally, in the guidance, the New Zealand formulary, the guidance that us doctors and healthcare professionals really we should be practicing by says the use of hormone therapy should be for moderate to severe hot flushes in the post-menopause. So, and why? Oh, because hormone replacement therapy, this is wrong, by the way, increased rates of heart attacks and strokes and breast cancer. That is wrong. But if you bear that in the back of your mind and you go and see your practitioner and they aren't in support of your thoughts, this is probably their concerns. Then the other thing is, a lot of people don't know the benefits of what HRT could do for body pain. So as part of this conversation, you need to be knowing, and we'll help today to be able for you to gather that evidence for you, if this is kind of, what you want to explore, to set you up to succeed. Because I wouldn't criticize my colleagues for not prescribing it, but I can definitely understand why this is not top of their radar. And so this is why that paper is going to be in the show links, and there'll also be a leaflet that I've put together as well for you to take with you to that appointment. And just be prepared, and you don't need to argue. But overall, you can say to your practitioner, this is the evidence about me that suggests my symptoms may be related hormones, and I'd like to try hormone replacement therapy. But I understand this isn't guidelines. But what has just been so validating this weekend for me that I'm really honored to share with all of you is that if we wait for these guidelines to happen, our health is going to worse, and there's going to be a lot of unnecessary suffering. So hormone replacement therapy is in essence two medications, estrogen and progesterone. So estrogen is what's thought previously to improve all of those symptoms, caused by, in perimenopause, the changing hormone levels, and in postmenopause, the low estrogen. In days gone by, it was an oral synthetic, so not made with our natural hormones like our body, medication. And oral estrogen goes through the liver and increases rates of blood clots, and the synthetic ones do even more so. So increased rates of blood clots, particularly as we're getting older, it's a concern, right? But newer body-identical transdermal estrogen, so estrogen through the skin, gel or patches, both funded in New Zealand, don't increase rates of blood clots. So, and I bet we've got a reasonable proportion of wahine who have had blood clots in their legs because of other autoimmune conditions, inflammatory joint diseases. So you will be more prothrombotic. but actually you can have transdermal estrogen. And we can even include a letter in the show notes from the British Society of Haematology supporting that prescribing. So in perimenopause, estrogen is going up and down, right? And the HRT we give is a tiny dose. So I describe it as buffering and supporting these big changes. So often it's not an overnight, it takes time to work. And in perimenopause, with these huge fluctuating levels, we often need higher doses to get symptomatic improvement. And one of my other take-home messages would be, and this is my opinion, I'm happy for you to quote me on it, but it's my opinion, it's not guidelines, there's no evidence on it, it's what I kind of observed, that a lot of the old data is based on lower dose estrogen, and that improves hot flushes in 60%, the lower doses. But there have been papers published about pain and mood and about estrogen and HRT improving symptoms of schizophrenia. These are all on higher doses. So if your main symptom is body pain and you're in the perimenopause and you're not improving on lower doses, discuss with your practitioner, do you need to increase it up? So one of the things estrogen does is it thickens the lining of the womb. It needs to do that as part of the menstrual cycle to provide a nice little bed for a developing baby. Over months and definitely over years, what we call unopposed estrogen, so estrogen with no progesterone, means that there's very high rates of endometrial cancer. So if you still have your uterus, your womb, your fare tangata, then you need to have a progesterone or a progestin, both of which come under the umbrella of progestogens, to protect the lining of the womb. And then, if you're on the right amount, you have a lower risk of endometrial cancer. In days gone by, and particularly with the synthetic progestins, it's thought that they only protected the lining of the womb. And the synthetic ones did a really good job of that. However, we now have a body-identical progesterone. And this progesterone protects the womb, but it also crosses into the brain. And in some women, and I've seen more at perimenopause, it really improves sleep. And studies have shown estrogen and progesterone can improve sleep. So if we're thinking about pain and sleep disruption, is it a sleep disruption that's your primary issue? Or is it the pain? And do we need to think of both of these together? There's also some of my patients find that progesterone is the absolute game changer for their pain. Once again, off license. But if you take it and you feel that's improving your pain more than the estrogen, have a discussion with your practitioner. Because, if we prescribe estrogen and progesterone and that's safe and I can do that, well, if the estrogen's not doing you anything, but you love that progesterone, that could really have benefits for you. If you don't have a uterus, so if you've had a hysterectomy, then you don't need to have progesterone. As we go forward over the next few years, I think we will see progesterone having a new self-defined role. But some women who've had a hysterectomy, I do use progesterone for sleep and pain. So if your sleep and pain isn't improving on estrogen-only hormone replacement therapy, give progesterone a trial. A Mirena is another form of progesterone. It's a synthetic progestin. It's a little T device that sits in the womb and causes the lining of the womb to become thinner. It's a low dose and it's pretty safe overall. If you have a Mirena, you do not need the utrogestan. But once again, some people find having that extra progesterone really helpful for their pain and for their sleep.
Yeah, it was great just having that knowledge. And I didn't know that you could just do the progesterone. But it's But I think that I feel strongly enough to say, why can't you?
Yeah. The guidelines don't support it, but there isn't evidence. And, I've got definitely some women that just cannot tolerate estrogen. And others that actually I might, in quote marks, load up on estrogen first and then introduce the progesterone, or load up on progesterone first and then increase the estrogen, depending on tolerance and symptoms. Can I just go a little bit off tangent again?
Absolutely. I'm loving it, Sam, so please do.
So there's a hormone called testosterone.
Mm-hmm.
So testosterone is thought to be a male hormone. But actually in women, we have testosterone. And testosterone drops from our mid-20s onwards. Some women find that actually testosterone supplementation in perimenopause and postmenopause improves their pain as well. Testosterone is only licensed in Australia for low libido, hyposexual dysfunction disorder. So to get a diagnosis of this, you need to go to your doctor and tell them that your libido is low, it's impacting your quality of life, it's been going for 6 months, you aren't responding to sexual clues, and you're not responding and having spontaneous thoughts, something like that. Men can just go to the pharmacy and buy Viagra over the counter.
Not fair.
But so that's what testosterone is licensed for. But in my experience, there are some women who testosterone is really helpful for. And often those women that have had a higher testosterone drive in life. So my women who have had polycystic ovaries, I'll often talk about testosterone earlier in our hormonal journey because we're more sensitive to that relative drop. It'd be amazing to do everyone's testosterone at 28 and then again at 45 and see if it's dropped and they might benefit from it. So unfortunately, the female preparation of testosterone is unfunded, and we don't have heaps of data on it. But I think, if you're not winning with your body pain and looking at quality of life, just tuck that one away and watch this space.
Yeah, no, it's an interesting one. It's certainly being talked about a lot more, and I know I have friends who take it, and it seems to definitely help. But I think again it's down to that individual. Everybody's different.
Totally, yeah,
and I think that's the reality of it.
Yeah, totally. And me giving women choice. I don't think that hormones is for everyone, one from symptoms or risk or actually just in your heart. But I have realized that I really, really strongly believe that everyone should have a choice, because it has blown me away how women who didn't think they didn't feel well suddenly feel better. And I think if you're not told that, why would you go and look for it? Over 90% of women get menopause and perimenopause related symptoms. Worldwide, 4% of women are on HRT. And HRT is the best management option for menopause. Improves mood, if it's reproductive related, hormone related, in 80 to 90%, and hot flushes. It improves, we don't have data about body pain, but actually saying that, I did a survey about, for those who know about estrogen, you may know that there was a shortage of some of the estrogen preparations. And I didn't really know what to do. So my friend helped me and we made a survey to capture these stories because, that's what matters. The stories are what make change. And with respect to mood and pain, I asked people what other medications did you need to stop, or what changed once you started hormone replacement therapy? 85% of people had an improvement in sleep. 33% decreased their antidepressant medication, and 17% decreased their pain meds. And I heard a study at the weekend that actually had similar stats. So what does that tell you? Forget about whether hormones is right or not, but what does that tell you that hormones do to sleep, mood, and pain?
Yeah, massive.
It is totally. It's exciting. I think we've got to spin it around. The women that came before us that actually weren't supported to try this, and it wasn't discussed. They've now said at a conference I was recently at in Australia, not this weekend, that we can look at prescribing transdermal estrogen in women up to 70. I think that it's all about what are the risks and benefits. And lower dose transdermal estrogen in particular, and even more so when started in the perimenopause, it decreases rates of cardiovascular disease by 30 to 50%, diabetes by 30%, osteoarthritis, inflammatory disease, mental health conditions, colorectal cancer. And it's just thought that if we start estrogen later in life now, so in our late 50s and 60s, it's probably not so protective from the cardiovascular perspective. But even starting estrogen in our late 50s and 60s is thought to improve bone health and strengthen bones still, even just a little smidgen of a dose. So
yeah. Which is massive. And actually we get a lot of questions around around that, sort of saying, can I start it later? Yeah, is that an option? And I think, for that bone health in particular, and particularly if you've got arthritis as well, it feels very prevalent, and definitely something to look at and to discuss with their health providers as well. Just within all of that, you talked a lot about what sort of things you should be asking your GP, and I guess it'd be really great if you could just sort of be a little bit more succinct for our listeners, just about around some of the key questions that they just need to make sure that they're asking, that they're covering, with their GP around menopause and arthritis.
So as a GP, I don't want to miss an inflammatory and autoimmune condition or an infection. So, your GP should ask you what your symptoms are, and that is their job. So almost let them lead the way. But frame to your GP, do you think this could be hormones because of this, and this? So go armed with the research paper and with something called a green climacteric score, which is a score summarizing your hormonal symptoms. And also be aware of what the benefits HRT could give you. So tell your GP if your sleep's been impacted by hormones, worse premenstrual or worse since your periods have stopped. What's your mood like? Have you had a history of mood things? And are you getting hot flushes? Because as a GP, to know if HRT is working or not, I love it when someone says they've got hot flushes, because I'm like, yes, bosh, I know it's working. Or, oh, okay, we need to increase the dose. So, do look at yourself through a hormonal lens. So what has your hormonal journey been like? What was your puberty like? What was your pregnancy experience like, if you had any pregnancy experiences? What were your periods like? What's been your response to the pill? And then what are you like now? Are you having premenstrual syndrome? When did your fibromyalgia get diagnosed? Could it be hormones? And actually, we need to reframe it, and even me as a doctor. And I'm going to tell you about a patient here and why I love this in general practice, because I do routine general GP as well. And I had somebody come in who just moved to the practice and wasn't getting enough paracetamol for their body pain post injuries and things. And I was like, oh yeah, sure, that's easy. And she literally had nothing else. And so I looked at her dashboard and I was like, oh, you're 52. You're not working because of your body pain. You had a hysterectomy at 40. You had postnatal depression. And I was like, how's your sleep? She's like, oh, I don't sleep. Okay. How's your weight? I didn't say it like that, but I could see from the measurements it had gone up quite a lot. And so in 15 minutes, I just said to her, do you mind if I ask you something? And she was like, yeah. I was like, can I say something really out there that I know you won't be thinking of and that other people won't say, but do you think it could be hormones? She said, no, of course not. I had a hysterectomy 10 years ago. And I was like, that's really interesting, because in my experience, sometimes we don't realize. And her pain started 10 years ago.
Wow.
And so I said to her, well, in my experience, because I feel I can strongly and confidently say that now, in my experience, I've seen hormone replacement therapy at sometimes higher doses improve body pain and sleep and mood. And we just don't realize it's hormones. It would decrease your risk of breast cancer risk is increased more through obesity and having 2 alcoholic drinks a day. Would you like to try it? And I was like, look, I really appreciate this is totally out the blue. You've not met me before. We haven't really got a relationship yet, but I just, it's something I actually feel quite strongly about, that it may help. And she was like, yeah, okay. So I said, well, I'd expect that you need a high dose based on my experience. So I prescribed her a 50 microgram patch to start and some Estrogen, because I felt I needed to get some trust. I warned her about the side effects, but I was like, I need to get a benefit to kind of make her believe me a bit. And yeah, she's decreased her pain meds.
Wow. That's such a great story.
It's really incredible, And I think it's, if all of us go into our doctor and say, I want hormones to get rid of all my pain, your GP is going to go, what? Yeah. But also, we don't necessarily want to get rid of all of your pain. What happens if we could drop your medication load by 5% or improve your pain by 10% or your sleep to help you with your pain? And what would that do for you as an individual?
It's the balance, isn't it? It's about how it all works together, which makes so much sense. It really does.
And I don't think we're medicalizing menopause. For years, women have been dismissed and told you're hysterical and crazy and you need to have a hysterectomy, or if you get pregnant, you'll calm down. So actually, that's dismissing menopause. But now we have a safe, effective treatment option that improves life expectancy by 2 years when taken in the menopause, starting the perimenopause. We really don't have to be scared of it. And this is what we need to reframe.
Yeah. It's that. Well, I think it comes back to that awareness, and it's getting people talking. It's about getting people talking about it as well, which I think it's happening, but we still need to do more work on that as well. So, it's great what you're doing out there, Sam. I absolutely love it. I think I'd come to the Hawke's Bay to come and see you.
Thank you. Yeah, no, I feel pretty honoured. Like, people travel really far. My furthest was from France.
Wow.
So, yeah, real honour. Just feel really privileged to be able to help. And, when I first started, I'd worry that HRT wouldn't help, or that, looking at it wouldn't help. And now I feel that, well, that's not, we've got to give it a go. And as long as you as an individual and I am realistic, then let's consider hormones.
Yeah, it's great. I love it. Love it. Sam, I thought we'd just finish just with, I guess, your top 3 tips for women who are dealing with menopause and arthritis. And then we can just sort of, tie things up after that.
Well, so I think, the first is it arthritis or is it hormones? So what are your options? Present your evidence, body pain, recurrent injuries, and look at it through a hormonal lens. My number 2 would be weight training and LHS, which is lift heavy shit. But that protects it stimulates muscles, it protects our joints, it improves our brain health. But you've got to build up to be able to weight train, let alone lifting heavy. So, I often talk to my patients about that. So, that's a goal. But I've been really, it's amazing how much of a difference, weight training helps and can improve bone density. And then another thing is kind of a little bit of the small print. But when women feel rubbish, they often have a habit of going dairy-free. And dairy is our largest source of calcium. So I don't have a problem with dairy-free, but I do really worry about no calcium in diets. So do a calcium calculator, because even if you're lifting heavy, eating protein, getting vitamin D, if you don't have enough calcium in your bones, then you're going to get increased rates of osteoporosis, which is much higher in women. And in the menstrual cycle, calcium can also help with premenstrual syndrome too. So they would be my 3 tips. Is it arthritis or hormones? Weight training, and have calcium.
Great. That's just so helpful. That's brilliant. Sam, I just can't thank you enough for joining us today. It's been so interesting, and it just sort of it brings everything together, and it all starts to make a lot of sense, which I'm sure it will be really helpful for, a lot of our women with arthritis who do have a lot of pain, and they want to know how to manage it. And you've certainly given them lots of ideas and lots of information. So thank you. Now, Sam, I know you've also offered some courses as well. It'd be great if you could just talk quickly about them and let our listeners know.
Yeah, I had so much in my brain, I needed to get it out. So I have designed a course called Is It Hormones that reviews in a bit of a more detail as to what we've done. And I've made a booklet to help you with the GP, with your journey with your healthcare professional. There's a 50% off code, which will be in the show notes. We've called it ARTH50, with links to the course. And I've called it All About Us because I think it's not just about women, it's about family as well. And I am just going to launch actually a moderated moderated hormone-based community called Female GP Connect and the Connect community. So just to help that good evidence-based information get out there, that me and going to rope in some of my GP colleagues who have this interest as well to just help spread the word. And that will be $10 a month, and you'll get access to submit questions for a monthly question and answer webinar. And I'll make another webinar on a different topic each month as well. So, yeah.
Fantastic, Sam. Webinar queen. We love it. Thanks again. And everybody's listening, don't forget to look out for further podcasts as we'll continue to delve deeper into your questions around menopause and arthritis. And we'll post some of those show notes and links around what Sam's talked about today.